Hello, and welcome to the Ask Nurse Linda webinar. It's Webinar Wednesday of the month. Somebody just told me that. I want to thank the people that put on all of this, all these webinars, because they are the ones who do the technology, and the information specialists will put things in the chat box for people to see, which is always very helpful. And so there's just a lot of people behind the scenes that I'm just a talking head for people who make this happen. It's not me. So I want to thank them very much for another year of great webinars. So my name's Linda, and I am a lightly pigmented skinned woman. I have brown hair with some silver streaks. I'm wearing flesh tone glasses, and I have a teal color sweatshirt and a light teal t-shirt on underneath because it is cold. And I have the Reeve background, which is navy blue with orange, yellow, and red triangles and behind me. So this is the holiday season for most people. Some people don't have any holidays this month, but a lot of people do. There's all different kinds of celebrations that's going to be going on. So I just want to remind people that to think about the holiday. And, we always think, oh, great, this will be a lot of fun. We're going to have a lot of things to do. This is going to be a lot of action. But remember, fun and action can be stressful as well. How am I going to get there? What if it's too cold? What if it snows? What if it's ice? What if it's rain? What if it's too hot? Because some people in other parts of the world, it's going to be too warm for them. So think about yourself a little bit, make yourself a priority, and think about what's happening and how you can deal with it. Maybe you want to, take a day off from your festivities. Maybe you want to come home a little bit earlier or sleep in a little bit later or whatever it is you need to do. Make sure that you're taking care of yourself. Now there will be a lot of food in anybody's celebrations. There's always a lot of food. So think about your eating and think about, well, maybe I'd like to have a taste of this, but maybe I don't need a whole piece of pie or, just think about managing some of your things because, people put a lot of weight on at the holidays. They sign up for the gym membership in January, and by February, it's all over. So, you can skip that whole phase and just think about your eating and your stress. Take some time out. You could even be at a party and just ask if you could, go into a quiet space for a while or, whatever needs to be done. So think about yourself. It's also in some parts of the country where we are in the northern hemisphere, it's very, very cold. In the southern hemisphere, it's going to be very, very warm. So think about temperature control and how you're going to manage that, what you're going to do about that. Try not to get overheated. Try not to get too cold. Even if you don't sense the cold in your body will still react to the cold and will still react to the heat. So dress appropriately. If you're in the sunshine, wear a wide brimmed hat. Have some place to go where you can go cool yourself off. Put on sun protectant lotion. If you're in the northern hemisphere, please dress for the weather. I still see people out that go outside in this cold, cold, cold weather that we're having, and they'll have no shoes on, and their poor little feet are all red and their skin is dry and flaky and they're having, they stub their toe into something because they hit their wheelchair to get something. There's no shoe to protect their toes. So think about your feet. Care for your body. It's your machine that you're getting around in. So think about that. So take care of you. That's the important message for the day is to be sure and to just take care of you. So we have some questions that have come in, and I think I need to turn on my question and answer box here in case somebody wants to type a question in. I can read it. We'll get going with your questions if you have one today. So somebody had written in about being on a ventilator. And there's some things that are going on in the world today where you can get off the ventilator now. If you didn't know that, it's time to know that. So you might say, "Oh no, I'm permanently on this ventilator." But there's some different things that are happening in the world out there. There's a diaphragmatic pacemaker that can be put in your body. It's on the market now. You only need to go to the doctor and ask for it. Um, the company that makes them will work with your insurance to help you get one if you qualify. Now, maybe you don't qualify today, but maybe you will qualify in a few months or a few years. So, don't think, oh, they said no, so that's it forever. No, things change all the time. They're going to improve the pacemakers, which are great right now, but they'll keep improving them and making them smaller and making them more convenient, making them cheaper. So all these things will happen as they go along, but they are available now, and you can have it done anywhere in the United States. You can have it done outside the country as well. The Cleveland Clinic is the people that were really the instigators of the diaphragm pacemaker. So that's if your doctor doesn't know where to go, you can tell them it's at the FES Center in the Cleveland Clinic. If there's not a surgeon, any surgeon that does thoracic surgery can put these pacemakers in. So you don't have to go to another place, another city to get this thing. You can have it done right in your hometown. Now, if you live in an extremely rural area, you might have to go to a bigger city where there is a thoracic surgeon. If they have never put one in, the doctors from the Cleveland Clinic will train them how to do that, which is kind of wonderful for the doctor where you are because then he'll have a whole new skill set. But it's done with a procedure, it's done with a surgical procedure where some wires are inserted into your body and they attach to your diaphragm. And then there's a machine outside your body that controls your breathing. Now, some people will get off the ventilator completely with this. Many people will be off maybe during the day, but still have to go on at night. So there's all different kinds of levels of things that will happen with this. This is available right now. So really cool. Um, Being on a ventilator is one of the big things that can reduce your lifespan. So being on the diaphragmatic pacemaker gets you off the ventilator, which then can help your lifespan as well. You can speak more naturally. You can do coughing with these things. You can, they just are really great. As I say, it's not for everyone. It won't be like it was before you needed ventilation, but it's such a huge improvement. So I just wanted to comment about that. The Mayo Clinic also has a big setting. They have several sites around the world. They're also big proponents of these. But anyway, those are available to you. Insurance kind of favorable towards them because if you're off the ventilator, then you don't need as much attendant care. And so it's really in the long run, it's less expensive for them to get you a diaphragmatic pacemaker than to pay for attendant care. So, it has its trade-offs. It's very frightening at first when you're on that diaphragmatic pacemaker. Usually there's a transition time. So, don't worry. It's like your ventilator's gone and you're like, oh, holy smokes, now what? I'm scared to death to go home by myself. There's a transition time. There's periods, where they monitor and that, and then when everybody is comfortable that it's working perfectly fine, then you'll be on your own with that. And so it's kind of a cool thing. You might need somebody to hook it up for you if you're on and off or, to do different things, but that's a lot less than having somebody with you. Now, if you have gotten off the ventilator yourself, because there are people who are at that transition zone where maybe their injury or their brain has healed enough that they don't need to have the ventilator anymore, and so you can start weaning off the ventilator. And then, but oftentimes the trach is left here. It's kind of surprising to people to find out to draw in breath through your nose takes a lot of work and a lot of energy and a lot of muscle power. And it takes nerves to power all those muscles to bring that air in through your nose down into your lungs. Actually, when the air comes out of your lungs, it's more of a relaxation for your lungs. So that gets pushed out. But to get that air, it's very hard. If you're breathing through your mouth, if you're breathing from your nose, you've got this much to this much space that it has to go up back through your nasal passages and down into that esophagus. So breathing through your mouth is a lot easier than breathing through your nose. Now, you don't have the filter that your nose has to filter the air. It's got an automatic filter in there. That's why you have nose hairs and mucus and all that stuff. It's a lot of those germs before they get into your lungs. And so your mouth doesn't really have that protection. So breathing through your nose is better. But if you have a tracheostomy, now imagine if you're breathing through here instead of up through here. That's a lot of space that you don't have to use your muscles to pull that air into your lungs. But there are exercises that you can do. So if you want to get off your ventilator or you're in the process of doing that, or you just have weak muscles, you can exercise your lungs anytime. Anybody with paralysis is going to have weak breathing muscles somewhere in their body. It could be from something in your brain. It could be from that spot in your spinal cord. It could be from neurological disease. But there are muscles that we use. We use the muscles in between, little tiny muscles in between our lungs help. And then there are muscles, like if you see me breathe in, you can see me how my chest rises because that's muscles breathe, pulling that air in. Muscles in your back help you breathe, and muscles in your abdomen help you breathe. So if you've had a stroke or you had a lower level spinal cord injury, you might be breathing on your own, but maybe not breathing as strongly as you could. So there are exercises you can talk to your doctor, ask to see a respiratory therapist that will teach you some exercises that you can do. And always, I speak in generalities. This is the most common thing. This may or may not work for you. So always check with your healthcare professional before you do anything. But there's also some breathing exercises that you can do using a straw. So if you start out with a big straw for like a smoothie, they have a very wide diameter and you breathe through that, and then you move down to like a soda straw, and then you move down to a smaller coffee stirrer straw. Anyway, there are different things you can do. You can make them different lengths. You can cut the straws and make them shorter so it's a little easier instead of trying to pull the air through a fully long straw. So there are all kinds of things that your respiratory therapist can help you do to help strengthen your lungs. And if you have stronger lungs, that's going to help you cough better, and that's going to help you through this cold and flu season. Now, I just heard on the news this morning that there's a new flu that's going around, and it's pretty contagious, and that we should all be very careful. So we need to go back to our careful hand washing. If you've given that up, it's time to go back. If you feel more comfortable wearing a mask, you might want to try to do that. If you have breathing problems, you shouldn't wear a mask. So check with your healthcare professional, because if you're having a hard time breathing in and you put the mask over, well, it's going to be even harder to draw air through that mask. Now, the flu virus is bigger in size than the COVID virus. So, masks work pretty well with the flu virus. Nothing is 100% certain. You can still get it no matter what because it's around us in the air. So even though nobody's had it in your home, it can come in from the outside. Viruses are just all around us. So, be sure and do your hygiene. Be sure and wipe your wheelchair wheels because we don't want you to get this bad strain of flu. I hope I don't get it too. So always check with your doctor before you do any of these things. This is one of the wonderful things that's already come out. It affects a small number of people, but it doesn't matter if you're in that small number of people and you can get a diaphragmatic pacer and you think you are comfortable in doing that. I'm not saying you have to, you don't have to do anything I say, but if you are comfortable, investigate that, think about that, and see what your options are. Talk with your healthcare professional. Maybe he'll say you need to wait a while, or maybe he'll say you need to do some respiratory therapy first, or, any of 1,000 things. Now, they also have some stimulation to the phrenic nerve, and that's an implant that goes in. And that can help you with breathing. The phrenic nerve is one of the big lung nerves in your torso from your brain, down through your body. The vagus nerve is another one. And there's stimulators for both of those that can help breathing, bowel control, digestion. So there's stimulators for that. That's a surgical procedure that they usually do a little tiny, like half-inch incision along in your neck or upper area, like in here somewhere, depending on how your anatomy is. And so those are something that are available too. Some of those are still under study, but there's a lot of possibility for those stimulators to do some good things for your internal body. The Vegas one, they're thinking about that might be a potential treatment, and this is just a thought now. They're doing the research on it, but it's not available now, I don't think, for this particular treatment. But they're starting to do some, sorry about that. They're starting to do some studies on if that stimulation of that vagus nerve will control autonomic dysreflexia, which would be really wonderful. If you have that, you know what that is. It's an inability to control your blood pressure and all the automatic parts of your body. And so it can be really dangerous if your blood pressure gets too high. And so it's something to think about in the future, but that looks like that's going to be a real thing. And so while I'm talking about autonomic dysreflexia, there was a question about that. Oh, the question was, what's the range of having an uh, dysrec, autonomic dyslexia episode? And so your blood pressure goes up when you have an autonomic dyslexia episode. And we have a wallet card. Autonomic dysreflexia is an emergency situation. Now, if you have it and you know how to treat it, then you're good because people who have it, it pops up a lot and they know what to do. If you have one for the first time, you're going to need medical attention. And we have a wallet card for autonomic dysreflexia, sepsis, and DVT that you can take with you can give to the ambulance drivers, you can give to the people in the hospital. If you have a child, you might want to give one of these cards. If your child has one of these situations, you might want to give one to their teachers or their caregivers. Be sure your caregiver has one so that they can recognize the symptoms. Now, the most common symptom of autonomic dysreflexia is a pounding headache, a severe pounding headache. You know it when you get it. You know exactly, oh, wait, I know what this is. Even if you've never had it before, you'll be like, oh, yes, I get it. And so, the first thing you need to do is lower your blood pressure as quickly as you can. And so, what we do is we take advantage of, how if you've had a head injury or spinal cord injury or neurological disease, and sometimes you get up real quickly and you're like, whoa, I'm a little dizzy, and you have to lay down because your blood pressure drops when your head raises too quickly. You have to get your body adjusted to getting up again. And so we take advantage of that in AD. So if you have an AD episode, you sit up real quickly or have someone sit you up really quickly, that will drop your blood pressure. And that usually works. But there's things that cause it, and there's a lot more symptoms that come with it besides the headache. So get the wallet card so you know all the symptoms. It can be like flushing, it can be goosebumps, it can just be like blurry vision, it can be it comes in all different kinds of forms. Sometimes people are only told if you get this pounding headache, then you have it, but it comes in other ways and it's not as severe, but it still has the cardiac complications because it's your cardiovascular system that's overreacting. And so that's why we want to take care of your heart and your blood vessels. So you need to get that treated right away. So, with the AD, so how do you know when you have it? What are the parameters? Well, after you have neurological injury, oftentimes your blood pressure changes and it drops lower. And it does that pretty quickly, but it takes a little bit of time, and your blood pressure will be lower. And so, if you're having the symptoms, any symptoms of AD, and you go to the hospital and you say, I think I'm having autonomic dysreflexia, and so they take your blood pressure and they say, oh no, it's 120 over 80. But because of your neurological disease and your blood pressure has dropped, your normal blood pressure might be 120 over 60. Well, if it's one, it might be 100 over 60. So if it goes up to 120 over 80, you're having an AD episode with cardiac consequences. So you need to have that taken care of right away. So check your blood pressure periodically throughout the day, throughout the night. Now, I'm not saying it like get up every half an hour. I'm just like one time a day, do it when you get up in the morning. Maybe the next day, do it before you go to bed at night. Maybe the next day, do it at lunchtime. Maybe the next day, if you're doing exercise, check and see how you're doing at exercise. If you wake up in the night for some odd then maybe you're catheterizing, maybe you're turning or whatever. On occasion, take your blood because something that has recently been discovered is some people have silent AD where their blood pressure goes up and they don't know it because they're sleeping and they don't really sense any of the side effects, any of the signs of autonomic dysreflexia. So it can be quite a problem. So just in general, know what your blood pressure it is. Now, if you've done that, you've checked at different times for a week, maybe you only need to check it at different times, like once a week after that. It's not like this burden where, oh, wait a minute, 3 minutes have gone by. I need to check my blood pressure again. No, it's not that. It's not that. Just get to know what your normal blood pressure is. Sometimes when people have their bowel program, their blood pressure goes up, or when they do their catheterization, the blood pressure goes up. So it's just good to know those kind of things. Now, for adults, if your blood pressure goes up 20 millimeters of mercury, so 20 of those little lines on the blood pressure cuff higher, that's indicating autonomic dysreflexia. If it goes up 20 millimeters of mercury from your normal, not from anybody else's normal, from your normal. And if you're a child, it's 15 millimeters of mercury. So, as a parent or a caregiver, you would want to check the child's blood pressure again on occasion. It's not like this is like, oh, it's not like the bladder program where I have to catheterize on this schedule. Just check it occasionally so you know what the blood pressure is. Now, some people, blood pressure over time will return to normal. It'll slowly creep up and return to normal. It's also good to know what your normal blood pressure is because as we age, people sometimes they get hypertension and they need blood pressure medication. So as you age, your blood pressure can go up as well. And so if you have lower blood pressure and your blood pressure is going up, it might mean that you're having high blood pressure, even though it's in the normal range. So always check with your healthcare professional to make sure that you're doing everything you need to do to keep your heart in check. So there's a question, can blood pressure be a sign? Usually lower blood pressure is a sign of orthostatic hypotension, meaning you've raised your head too fast. Now, AD or autonomic dysreflexia is high blood pressure for you. But can somebody have a dropped blood pressure? I've not heard of it, but this is healthcare and anything can be anything. But usually, if you're having a low blood pressure reading, it's because your circulation isn't working well enough to get the blood pumped up to your head. Sometimes people who have been sitting for a long time will have an episode of low blood pressure because their blood will pool around their ankles because the legs aren't able to pump that blood. Even if it's just one side, if you've had a stroke, your leg's not able to pump that blood back up to the heart. So collectively over time, like throughout the day, your legs get swollen with edema and usually that's what that is. So here's somebody which is the next question on my list. They have an incomplete injury in their neck and they've had it for 20 years. They've recently started burning intensely from the waist down. Not the MRIs haven't changed, and so they've constantly gone downhill in the last year. Well, and I have two other people on my question list here who have the same question. They have this burning pain. This burning pain is so bad. That is neuropathic pain. Burning pain is those little peripheral nerves that are trying to tell the nerves higher up. I was looking out my window the other day, flight of ideas, but this fits into this story. So I was looking out my window the other day. It was such a beautiful day, and all the leaves were off the tree. And I was looking at the tree, and I thought, a tree is a lot like the nervous system. You've got the trunk, which are those big nerves that travel throughout your body, um, like the vagus nerve in your body, the sciatic nerve that goes down your legs. You've got these big nerves, and from those branch off medium-sized nerves and then into the smaller nerves. And those that are not in the brain or the spinal cord are the peripheral nerves. And those nerves are sensing something is wrong in your body, but they don't know what it is. And they're trying to send a message up to the brain, but it can't get there because it's either interrupted by the spinal cord injury or it's interrupted by interpretation from an injury in your brain. And so that the transmission can't get through. So the nerves don't know what to do. So what do? They scream louder. And that's what that burning is. It's those nerves that are saying, I need attention. Something is wrong here. Now, this burning feeling is called neuropathy, and it's nerve pain. It's peripheral neuropathy. If it's in the skin, that's where sensation is. And so it could be in the skin. Now, again, check with your healthcare professional. There are some over-the-counter drugs that you can get for diabetic neuropathy. That sometimes works because diabetic neuropathy is a nerve problem that sometimes works with people with uh, neuropathic pain from spinal cord injury, head injury, or neurological disease. So sometimes that works. Now you can get it anywhere. You can buy it over the counter. I don't say go buy it over the counter. It's kind of expensive. It's like 23, $25 a tube, and the tube is like only that long. It's not even as big as a toothpaste, big toothpaste tube. So it's kind of expensive. But if it works, then great. But check with your healthcare professional because I don't want you to spend $25 on something that we know is not going to work in your particular case. But it's just something that's out there now. And, a lot of people are using it. People with diabetes sometimes have this. If you have neurological injury and one of the side effects, secondary complications can be diabetes. So then you kind of have the double hit, the double whammy there. But that is working for some people. So check with your healthcare professional before you put anything into your body or on your body. So that's always an important thing to do. So that would be a first thing you could do. We also have a pain book that goes through every single issue with neuropathic pain. So be sure and get our pain book because it talks about non-medical treatments. It talks about things like biofeedback. There's oral medications that you can take, pills that you can take that go throughout your whole body that will calm that pain. There's bigger pills that have been developed that are just treat neuropathic pain. So there's all different kinds of treatments. Now if you have that burning pain, you probably don't need to start out with the big gun pills. You might work up to them, and I would hope not, but you might not. Sometimes people get an itch and no matter how they scratch it, it just won't stop. That's a nerve that's acting up there. So itching, burning, that's neuropathic pain. So there is treatment for that. And there's a lot of different treatments that you can do for that. So that's a pretty good thing. Um, so I'm happy to report that there's treatments for that. Now, every single case of neuropathic pain is different. Nobody's is alike. There are no two alike ever. So when you go on, if you decide you're going to try these medicines, you're going to get the medicine from somebody who's prescribed it before, and they have a good educational basis in how to prescribe these medications. And so they're pretty good about picking the right amount. But do not be surprised because they're going to start you on the lowest dose that they think is correct for you. And don't be surprised if some people say, well, that did nothing, so I'm not going to do that anymore. No, you just need a little bit more. So tell them that hasn't worked. Sometimes it takes up to 6 weeks to get the full effect of it. But in a few weeks, if you're finding it's just not working at all, and this is just really annoying me, call your healthcare professionals, tell them what's going on, and they'll give you a higher dose so that you can get through this time. Now, if you're on one kind of medication and then you need to go to another kind for whatever reason, sometimes people don't like the side effects with this one, they want to try that one. Sometimes they're going to go on to a higher level drug for more control. There's all kinds of reasons. You cannot stop any of these drugs cold turkey. You have to wean off of them. And you cannot start the new drug until you're completely off the first drug. I have people all the time that would come into clinic and they would say, okay, yes, I understand. I'll taper off of this. They come back to clinic. I didn't do what you told me. I stopped cold turkey. It was horrible because this is controlling apart your nervous system in your body, and so you need to taper off these drugs so that your nerves understand what's going on. They're looking for that drug, and if you just stop it, it's going to be more pain. And not only that, but when you go on the new drug, it's going to be harder to control your pain because the nerves have said, you're not doing this to us again. So you have to be very careful about that. Sometimes when people go off their drugs and there's no magic date, how long will this take? It's different for everybody, and it doesn't happen to a lot of people. Sometimes people will go off their nerve pain drug to try another one, and they'll say, "Wait a minute, I'm completely off my nerve pain drug and I'm not having nerve pain anymore." The body has learned to live without that pain coming through. It's learned how to control that. It happens not so often. It's kind of rare. For some people, it might take 20 years. For other people, it doesn't take that long. There's no rhyme or reason to any of this nerve pain stuff. You just need to know that these are some of the things that are going on out there. The one that's over the counter. It's it's I don't know the name of it, but I've been to my store and I've seen it on the counter. That's why I know how much it costs because I was interested when I heard about it. And so I just went to see. You have to go into the department where they sell like foot lotions, not like body lotion, but like where they sell the Dr. Scholl foot pads. You have to go into that department of the drugstore. And then you just look on the shelf and it'll say for nerve pain, and it's a lotion. It comes in a tube, and you just squeeze it out and you can rub it on. There's also balms and salves. If you go on Amazon, they have pages of these things. But again, I don't want you to just go out and buy this thing before knowing what you should get, because you could go through on Amazon, you could go through 100 different products and it might not be the thing that's right for you and you've wasted all that money. So, it might be that because of your condition and the amount of pain that you're having, the real intensity burning, maybe that won't help for you. But if you have a little bit of neuropathic pain where it's just like an irritant now and again, it might work for you. But talk to your healthcare professional. But anyway, it has worked for some people that I know, and for other people it doesn't. So it's just another thing to try. This neuropathic pain it's an interesting thing. Botox is another thing that is real big right now, and that some people take it for neuropathic pain. Some people take it for spasticity, which we now are trying to call tone, but everybody knows it as spasticity. So I try to use both. If you go to a very sophisticated doctor, they might call it you have tone, which is really more of a medically correct terminology. But it's always been called spasticity for years and years and years. So nobody knows what tone is, but we all know what spasticity is. So I just try to say both of those. And we have booklets that go through all of these things. If you have spasticity or tone, we have a spasticity booklet. We call it a spasticity booklet. So everybody knows what we're talking about. It refers to tone and what it is. It's the same thing. We have the pain booklet. We have a booklet for bowel, for bladder, for skin care, all the medical conditions that go with paralysis. And then we have booklets that are about like emergencies. I've talked on the webinar before about um, people who, plan for emergencies. And we all know, okay, the house is on fire. How do I get out? Where am I going to go to meet my family? That immediate thing. But think about if you have an emergency, now your house is burned down. Where are you going to go? What's going to happen after that? What about my medical equipment? I didn't have time to get my catheters out. I have no catheters. So I was just talking to a lady in Dallas, and they had had some bad weather down there, and she had to get out of her house right now, and they had to go. So she grabbed all the supplies that she could get and had to go to a hotel. Now, usually there are places where people who have disability can go to. Sometimes they will have people go to a hospital or to long-term care facility where they can get the medical treatment that they need because you need a special bed and you need all this different equipment and it's all been in your house and you know this is what are you going to do? So sometimes they make different arrangements for different people. If you talk to your electrical company and the EMT people and tell them that you're in a home, you're a person that has a disability, and this is what your needs are, they love to hear that because they put that in the computer file so that if the 911 call comes from your house and it says, oh, this person can't walk, they will know to bring the right equipment for you when they get there. They will know that if this person in this home is on a ventilator and the power goes off, they will know to get to your home. Number one, your top priority, because if your ventilator runs on electricity and the battery runs out, what are you going to do? Hopefully you've got an ambu bag, but somebody'd have to be using, working that for you. So they're very helpful and they're really good about doing other things to help people out. So that emergency book is good. And another book, the emergency book, and this other book called Victims of Crime. I say they're two booklets. They're just little booklets. Everything's free at Reeve. You can go online and you can get these and download them for free, or they'll send you a paper copy if you want, or there'll be a link that will come up and it'll tell you where you can find that information online. Go to the Reeve Foundation. We have all of these booklets to help you. But the Emergencies and Victim of Crime book, I always think these are two booklets that you should read, but I hope you never need. But read it, just tick that information in the back of your head because it's really going to be helpful in knowing what's going to happen next. Um, okay, I wanted to bring some other things to your attention, and I've got this PVA handout. I'm going to put it up here. Let me see if I can hit the camera just right. Oh, there we are. There it is. Okay. This is called, oh, it's backwards, isn't it? It's called Making Architecture Accessible for America. And it's a book that Paralyzed Veterans Association has put out, and you can buy this on Amazon. Now, it does cost $15 if you're a non-member. If you're a member of the PVA, it costs $10. But they also say to contact them because if you're a vet, I think you get a discount no matter what. But don't hold me to that because I'm not a vet, so I don't know. Okay, but this Making Architecture Accessible for America, if you're thinking of doing something to your home or you're wondering just what to do with how to get a ramp in. Now, this is about the actual construction of these things. A lot of people are having difficulty in finding somebody who can put grab bars up in their house because contractors do not want the liability of putting a grab bar into the house and then you fell and then they put the grab bar in and so then they're liable. So it's hard to find somebody to do that, but it has information on how to put in grab bars. So it's like simple things, but it's also if you want to redo your kitchen or if you need to redo your bathroom, gives you lots and lots of ideas to think about different things that will help you, that will help make things better for you. So these are all it's all very, very helpful. So it goes from like tiny little projects around the house to like great big projects. So I have a friend that moved into senior living and the ceilings, it's kind of odd. I don't know why this is, but the rooms are regular senior living size. They're not huge, but they're not too small. They're nice, but the ceilings are really, really high. I don't know, they're like 14 feet or something. I'm like, what the purpose of that is? I don't know, but they're really high. Anyway, and maybe it makes it just space feel larger. I don't know, but it's it's a lot of wasted space up there. But they have cabinets that go very high. And so they're like, well, I'll just put everything in the bottom cabinets and those upper cabinets will just stay empty. And I said, well, you can get shelves that you can take a reacher and just pull the shelf down. I think most people know about this. I've seen it on shows on TV. I've seen people have these. And so it's pretty common knowledge, but yet, there's always things that are new to everybody. And so I said, you can get these pull down shelves. And she had a son-in-law that was pretty handy. And he said, yeah, he could come put those in. And then she has this whole bank of the higher level kitchen cabinets that she can use for different things. So that was kind of a big thing for her because, she's trying to pare down her life to move into a smaller space. And so that's kind of so that architecture book has just everything. You can go to a store that does home remodeling, refinishing, and ask for handicap adaptions, accessibility adaptions, and they'll show you a bunch of different things. They won't know what you really need, but if you get this book, and again, it costs money, so you want to think about that ahead of time. But if you're thinking about doing something um, in your home, that is a very, very good resource to get. You could also go to your public library and ask them to purchase the book, and I bet they would do it. And then you could check it out, but so could everybody else if they're looking for something like that. So that's another good option as well. There's a person that wrote in about the spasticity, and they said it's a northern word for spasm, and he wrote in about clonus, and clonus is a type of spasm where your body keeps spasmodic rhythmic motion. So it just keeps going. It's not like a twitch spasm. Clonus is a rhythmic motion spasm. So that is the difference with that. But I thank you for bringing that up because I don't know if a lot of people have heard that word before. So there's a difference in just a spasm like a twitch and clonus, where it's usually the leg. It can happen in the arm where it gets a beat and it just keeps going like that. So I wanted to talk about some things I get a lot of questions about what's going on in research. And I was just, as I mentioned before, I was just down in Dallas and people will come up and say, what's the new research? Because the Reeve Foundation, we have a wonderful research section and we have the Paralysis Resource Center where you can call for questions about your care today. We have information specialists there that can answer any question. I mean, any question at all. They're so wonderful. You can message them. You can just go in through the website. You can call them on the telephone if you're more comfortable doing that. So they just have everything you would ever want to know they have. And they have a booklet or a paper or something that they can send to you. So it's very nice. So it always surprises me when people don't know what's going on, the big, big things that are going on. Now, the minutia in the research, which is all wonderful too, because every step is a step closer.
Hey everybody, looks like Linda might have frozen. We're just going to give her a moment to reconnect with us, so just hang tight.
Okay, I'm back. Okay, good. I was having a little panic there. Okay, so there's a lot of things that are going on in research, and Marco Baptista is our chief researcher. So he's the head of that department. He's been in the professional webinar that we've done, so you can look up and hear some of his thoughts. And he's having a progress in research newsletter out on the Reeve Foundation, and so you'll be able to get the link to that, and it will have a lot of information about what is going on in research, and some in what I call, like that microscopic kind of research, but how it's moving forward, how it's advancing. I don't think I have ever lived in a time when there's been so much advancement in our research as there has been right now. So I want to talk about some of those things because I think people need to be aware of these things. Think about it for yourself. Some of these things are in the future and some of the things are right now. So I told you about the diaphragmatic pacer. That's out right now. That's been research, ongoing research still going on to help more people, but you can get that right now to help you with your breathing. Um, there are some other things that are going on in research. And that is something that's out now is you can get if you've had a stroke or you want movement in one arm, there's a bionic arm you can get that you put it's a glove that you put like on your arm and it connects with your nerves that do work in your body to give you some hand function. They also have one for amputees that will make a link with the nerves up in your residual arm and that helps with movement. The exoskeleton is that thing you might see where people use as braces on the leg. There's a big power pack on the back. That is out for people to have now, and I don't know that a lot of people are aware is covered by Medicaid, and we've had people that have worked on that and have gotten that through, and so that's quite wonderful. If you think the exoskeleton might be something that you might like, you should certainly look up exoskeleton. There's a couple of companies that make them. This power pack that comes on your back is kind of heavy. It's for people who have lower level injury. You can use it at home, but it's supposed to be used for therapeutic exercise only. Now, some people like it. It's wonderful exercise because it moves your legs. You do have to use some canes or a walker to move with it, and you should always have a person with you while you're using it. If you wanted to do an hour of exercise walking around your neighborhood, walking around your house, whatever you would like to use that, maybe you would want to use it sometimes at work. It's very difficult for people with paralysis to walk. You have to hold up your body, and the exoskeleton helps you do that, but there's still proprioceptive coordination that your mind is not thinking about. So it takes a while, but you can ask your healthcare professional if that might be a thing for you. It's usually for people with lower level injury or neurological disease. And you can try that out in a therapeutic session and then see how it goes and see if that would be the right thing for you. Um, let's see what else is currently out there. Um, Well, there's just a lot of things that are going on out there, but there's some things that, currently out there is the ARC EX. And I talk about this a lot. I try to bring it up a lot and when I went to Dallas, I was surprised that people had not heard of this. I call it, and this is really as simple as I can get it for my pea brain. It's a piece of tape that goes down your back and it has electrodes in it. The electrodes attached to a box outside your body. The tape goes down your over your spine, the outside of your skin, no surgery. On the outside of your skin, it goes down your along your spine. It's maybe like about 12 inches longer, maybe it's a little longer than that. And it's about 4 inches wide. Well, it's probably longer than 12 inches, but just tapes over there. You turn on the stimulator and you have to have some therapy. You have to learn how to use it. And then it helps with hand function, it helps with breathing, it helps your heart beat better. It has all kinds of things that go on inside your body that you don't know, but it's improving. But it's really for that upper extremity function. So, is it like you were before you had your neurological issue? No, it is not. It is not a cure. But if you had no hand function or little hand function, it's a huge step ahead. That is currently available. It's approved in the United States. The rollout is slow. That's a slower process because you've got to educate all these doctors, all the therapists, all the healthcare people that are involved in this. So it's a big, huge education program to get people to know how to do this. The one that's currently available is put out by Onward Medical, com. You can look up onwardmedical.com and you can read all about this. They have clinical trials. You might be able to get into one of those to try it out. There are oodles of other companies that are also working on the same thing. SpineX has one for children with cerebral palsy that where the tape goes lower in the back. The adult one on Onward, they also have the tape one. I'm not sure if that's readily available yet or not. Um, but the one with SpineX, it's spine and the letter X. Spinex has a similar, I just call it a tape because it's a stimulator. It's electrodes that are on your back, but it's all outside the skin. It's only for children with cerebral palsy, but they'll expand that to other diagnostic categories. And of course, the one for adults. Now, if you get it on your spine, that does more with bowel and bladder control, sexual function for males. We don't know about sexual function for females because that's more complicated process. And it might help with some like hip flexor movement, so it does some different things in the lower body. Now, can you have one that runs from your top of your spine down to the lower part of your spine? I don't think so. I don't think that's quite yet, but you know what? We don't know what will come tomorrow. That just might be the thing. I think it's kind of a very neat thing because the risk is low. There's no surgery involved. We started with the FES bikes, and that was years ago, and people still do their biking, and it's electrodes on the lower part of the body, and it stimulates your legs to do biking, and the bike makes the legs move, but you're doing it with your own muscle power because your muscle power's being stimulated by the stimulator. That was all external. Then they changed and they started implanting on the spine, and that's a really huge surgery, very risky surgery. And so people, that did well for some people, but it's not like it was before. And but that, it was a dangerous thing. So somebody got the bright idea, let's just try it with the tape on the skin. And by golly, it worked. It's right over the spinal cord. So that's probably the hottest thing that's going on right now. There's some new drug treatments that are out for neuropathic pain, and there's a lot of those. So I just want you to know we talked about neuropathic pain and how tricky that is. So there's a lot going on in neuropathic pain. Um, so and there's just a whole lot. If you go to Dr. Baptista's webpage about research, you're going to hear a lot more about what's going on with research that's going on at the molecular level. I also did a webinar with Dr. Baptista and Dr. Linda Jones, where she explained all of the different kinds of research by cellular level that's going on and where they are in the different progress. Now, it's very deep, kind of heavy kind of stuff, but she is such a good speaker that I think anybody would understand. It's a lot of content. You probably don't want to just sit down and listen to it, like all at once. But she talks about the different nerve cells, and this is the study that's going on with this nerve cell and what this nerve cell does, and this is how the study's going. And then there's this other nerve cell, and this is what's going on with that. So there's a lot of things that are going on to work towards a cure for what's going on. Now, with some of the nerve stimulators, is that going to be a cure? Maybe. As of right now, it's not a cure, but it makes things a lot better than things were before. But we're just starting with that. Maybe for some people, it might be kind of a cure. So I know a gentleman, and I've always only known him with his arms in his arm troughs. And he got in the onward study for 6 weeks, and he did the nerve stimulator for 6 weeks. And the next time I saw him, I've known him for years. He always had a full-time attendant because he had no arm function whatsoever. The next time I saw him, he picked up a glass and he says, "Hey, Linda, notice anything different about me?" He could use his arm, and that was after 6 weeks of the nerve stimulator. Now, that is an outlier. That is not going to happen to 99.9% of these people. I don't know why he had such good fortune with his, and he doesn't have the stimulator anymore, and he never lost his function. This is an outlier, but the potential is here. If we have one, we can have two. So I'm just very hopeful about all these things. And so I hope you will be as hopeful as well. Now, coming up in January, it'd be the second Wednesday in January. We have our next professional webinar that's coming up. and it's with Dr. Rex Marco, and he is a spine surgeon, and he's a very good friend of the Reeve Foundation, and so he's going to be on the professional webinar talking about people who've had spine surgery and what has gone on in their spine. So, when they say, oh, I had, my spine stabilized, well, what does that mean? How does that work? What does it look like? Sometimes in different facilities, they show you a picture of your x-ray. And of course, it's usually after the time that you just had the surgery. And people are like, I'm not too clear on what I'm really looking at here, because it's an x-ray and there's some stuff in there and I'm not sure what's going on. So he's going to explain all of that to us. So that will be very, very helpful. I'm really excited about that. He's a wonderful speaker and I'm really looking forward to that. Now, if you have any questions about, what we talked about today, or if you want to go back and listen to one of the professional webinars I mentioned, or we have one on the diaphragmatic pacemaker. That's a really nice one to listen to if you're interested in that. So all the Reeve webinars are on the Reeve YouTube channel. You can look up Nurse Linda, go on YouTube and look up Nurse Linda, and you can go back and you can look at any of these. If you missed something today, oh, I didn't get the name of that, or I didn't get the link to that, that'll all be up on the YouTube channel. Now, it takes about 48 hours to get them up. So this one won't be up till the end of the week. So, but if you missed something today and you want to know more about something, just let me know. So, on the end note, um, people are always asking, when's the cure coming? Well, we don't know, but I am just fully convinced that in my lifetime, I plan to see it. And now that's my personal opinion. That's not based on any scientific evidence. But what we have going on right now in the last year, the progress that we have made is so unbelievable. And I talk about, all these things, the exoskeleton, and oh my goodness, the uh, ARC-EX and all these things. They're wonderful helping things. So now some people are not interested in research. They're fine with the way they are, and that's okay. But it's good to know that these things are out there. It's good to know that hope's out there. As Christopher Reeve would say, forward, just move forward. And so I think we're really moving forward at such a great clip. Oh, there was a couple other things I forgot to. They're in study, not out yet, but in study. People are working on a lot of bladder things. So there's a home bladder scanner that might be coming out, so you can scan your bladder at home. So they're testing that to see what that would be like. So you would know, do I need to catheterize now? Can I wait a little bit? What's going on? I need, So that would be a little bit, give you a little more flexibility in your time. There's also a device that's coming out that will do urodynamic testing that will tell you if you're having bladder problems. So it does it 24/7. So if you have an autonomic dysreflexia episode or whatever, or if you're just fine. But then if your bladder gets full based on the pressure in your bladder, not the volume, when your bladder gets full, then your phone will tell you it's time to catheterize. And then you have so long to do that, but you have to do it. You can't wait. You have to go do it because you don't want your pressures to get too high. So these things are all like coming to fruition now, and they will be out in the next couple of years, barring any kind of unfortunate things that happen in the research world. But these are all, things that are in their final trials. So, they're when you get that close, they're pretty sure things. So with that, I wish you much luck, and let's look forward to the new year. Educate yourself when it's convenient to do so. You don't. Some people make it education of their neurological issues, their life work. It's great, and you know more about neurology than I or my colleagues will ever know because it's real to you, your experience in it. But the reality of it is the more you know, the more apt you are. Some people are all on board. Hey, I want that tape right now. I want that ARC-EX this afternoon. Other people are like, let's see it out there for a couple of months or a year or two, and we all think about it. And that's fine too. Some people are like, hey, I'm doing just fine the way I am. I've adapted, I'm comfortable. I don't need any more help. I'm good the way I am. And that is good too. So, all these things are really good. And no matter where you are, no matter what you're thinking, we have a lot of hope for the future. So, I'll see you next year.